Hi everyone, it's Dr. Baker Townsend, and I want to talk to you about some postpartum complications. You can see this is in chapter 33 of our Loudermilk text, and I encourage you to read it, as this quiz and this PowerPoint will go over the information in the book. So the first thing I want to talk about is perinatal death. This was in another chapter, but we never covered it, so I want to make sure that you understand. It's very devastating to a family when there's a perinatal death. Sadly, the family is expecting to have a baby this entire time, and then there's like overwhelming grief when the baby is not viable. So you want to let the parents express grief and emotions. Therapeutic communication is key during this phase. Allow your recognition of maladaptive responses. So if they act flippant or whatever their whatever their coping mechanism is that is not appropriate, just understand that they're going through a difficult time. Offer information about the cause. So if the pediatrician or the neonatologist or the obstetrician knows of a cause of death, and you can talk to the parents and see if they want more information. Of course, we're going to treat this baby just like we would treat any other baby that was born. We're going to wrap the baby, dry the baby off, put a hat on the baby, and allow the parents to hold the baby. Of course, we definitely want to talk to the patient about their decisions. We're going to give them options, and we have checklists about all the options that they have. After 20 weeks, there needs to be a birth certificate and a death certificate, and the baby will have to be referred to the funeral home for either a burial or a cremation. Of course, if the patient is open to it, we want to refer them to the chaplain and for social services. The next thing we want to talk about that you really need to know are signs of problems for postpartum hemorrhage. All of these you must know for your test. A fever over 100.4 on 2 separate occasions is indicative of an infection in a postpartum mom. Moms' temperatures do rise a little bit when their breast milk comes in, the full breast milk between day 3 and day 5. So there is a change, and there's a metabolic change that increases the temperature. But bacterial invasion is really noted at 100.4 on 2 separate occasions. Severe pain would be an indication that there's something wrong. Increased vaginal bleeding, that could tell us that there was a retained placental fragment that was still inside of the uterus that did not come out. So there was not a full involution of the uterus. Foul-smelling discharge could be endometritis, infection of the endometrium. So we always concerned about that. Redness in the breast, mastitis. Flu-like symptoms and fever, those go with mastitis. People feel so bad they want to lay on the floor. And then symptoms of postpartum depression. These start around day 10 to day 14 and can last the whole first year of pregnancy. So doing an assessment, we can do the Edinburgh Depression Scale, or we could do the PHQ-9, which is an assessment for depression. Postpartum hemorrhage is a significant cause of maternal morbidity and death. So it is defined as a loss of a bleeding and blood loss of 500 or greater after a vaginal delivery, or more than 1,000 for a C-section. If there is a 10% change in the hematocrit between labor and delivery and postpartum, we know there has been a significant bleed, and that's indicative of a postpartum hemorrhage as well. Sadly, it's often unrecognized until the mother has profound symptoms. Of course, we want to monitor very closely her uterus and her lochia output and her blood pressure, so we can make sure that we catch it as early as possible. You have another quiz, your hemorrhage sheet, so make sure you know your hemorrhage sheet with all your interventions, as it is a significant portion of the essay on the examination. Why do people have postpartum hemorrhages? Uterine atony. The uterus is just soft and boggy and tired, or whatever the cause may be, that it does not want to involute down or constrict down. It must constrict down to close the arterioles. So if it does not, if it fails to, we're going to have significant blood loss. So what are the Who is most likely to have a postpartum hemorrhage? It's those with a high parity. So the greater the gravida and greater the parity. So if you're para 5 and above, you have a very significant risk because your uterus has been stretched out so many times from delivery that it does not like to contract or involute down. Hydramnios, which is too much amniotic fluid, it overdistends the uterus, it makes it too big. The more distended or the bigger your uterus is, the more it does not like to involute down or contract back down. That would go the same for macrosomic fetus, a baby over 4,000 grams. Multifetal gestation, your uterus is stretched out very far and is just... It's been stretched out the entire time, and so it does not want to contract back down and involute down. People who've had a prolonged labor greater than 24 hours, their uterus has just worked for so long and so hard that it's just fatigued, so it does not want to contract down. A precipitous labor less than 3 hours, or 3 hours or less, it should say, it worked so hard for a very short amount of time that it really never got a break. And so a lot of times people with precipitous labors, they're at super risk for a postpartum hemorrhage and for vaginal laceration. The baby has can have bruising from being pushed out too quickly. And the use of Pitocin, when we make your uterus work harder than it wanted to, it's tired. Or the use of magnesium sulfate, when we relax the uterus, it doesn't want to contract back down. The worst case scenario is when you have a gestational diabetic with a big baby that is a high parity that we have to use, and that gets preeclamptic, and we have to use Pitocin and magnesium sulfate on. That is a nightmare. They're a huge setup for a postpartum hemorrhage. So there can be another reason why people can bleed is lacerations of the genital tract. That's with the use of forceps, with vacuums, or a precipitous labor that, you know, just went so fast it tore the baby. It tore the vaginal canal. Or even with a shoulder dystocia, and we had a perineal laceration. Retained placental fragments, that's where there are parts of the placenta still inside the uterus. Your body still thinks it's pregnant. It has not contracted the uterus back down, and therefore it is a cause for concern because you're going to continue to bleed because there is no involution of the uterus. So when you're trying to distinguish a hemorrhage from the uterus versus from the genital tract, it's pretty simplistic. If the uterus is firm, it's not coming from the uterus. So it's more than likely a genital tract laceration. Also, there is trickling of blood from the genital tract, and it's bright red because it's so close to where you're going to observe the blood. If the uterus is soft, it is the uterus because the arterioles have not contracted down. They're still open at the side of the placenta. Usually the uterine blood is darker and is more coagulated. So important to be on your lookout for a postpartum hemorrhage. If the uterus is soft, that's early recognition. Bleeding with a contracted uterus, we know that it's coming somewhere from the genital tract. You guys, an inversion of the uterus, sometimes people just continue to press on the uterus and massage the uterus and never actually truly find out the cause. And if they don't do it correctly with two hands, one at the fundus, one at the fundus and one over the suprapubic bone. If they just go in at the fundus, they can push the uterus out. That's called an involuted uterus, or an inverted uterus. And so, sadly, most of the time, these are surgically removed. A hysterectomy is what has to happen because of the severe bleeding. And then a subinvoluted uterus is when the uterus is not contracted down. It's contracted down somewhat, but it's still not contracted as much as we would like. So vital sign changes during a hemorrhage. Obviously, the first thing that's going to happen is you're going to have a widened pulse pressure due to the fight or flight hormones. You're going to have a massive vasoconstriction. So the systolic is going to go up, but the diastolic is going to continue to go down because there is leaking of fluid out of the vasculature. So you can see these trends in blood pressure, 120/70, 128/65. You can see how they continue to widen. Then, of course, the patient will get tachycardic, greater than 100 beats per minute. This is to circulate what available oxygen that we still have available that's being carried by our red blood cells. Then the next phase is when they become narrow. The pulse pressure will then begin to narrow because you've lost so much volume out of the vasculature that the systolic pressures are now starting to drop as well. And you can see that they're narrowed. And then lastly is you're going to have death of tissues, gray skin, necrosis, cardiac and respiratory arrest. Lochia. So, I'm so sorry about these two little things here. Scant, less than an inch, and a regular perineal pad. Light, less than 4 inches, moderate, greater than 4 inches, and heavy, saturating a pad in an hour. So you guys, this is when you need to be on your lookout. When you start to saturate a pad in an hour, we have serious cause for concern. And then a hemorrhage would be a saturation of a pad in less than 15 minutes. Of course, in order to get an accurate measure of the lochia, we would either catheter or have her void, put a new pad on, sit her up straight, and then check the pad in 15 minutes to see if it's saturated. We would not wait for an hour, obviously, because we're trying to detect the amount of bleeding, and we're trying to do an assessment so we can figure out next nursing interventions. This is a chart that talks about the postpartum hemorrhage. So you have the hemorrhage, you need to do your assessment, look at your bleeding and your shock signs. Of course, we'd want to do all your vital signs, heart rate, blood pressure, respiration, O2 sat. Anticipate that we're going to have to do a CBC to see how much we've lost. Blood typing and cross match should have been done on entry to the hospital with a clot placed on hold in the event of a postpartum hemorrhage. That is standardized nursing care throughout the country. We may have to do further studies. We may have to do a repeat H&H or repeat CBC if we're concerned about the bleeding. Of course, we do want venous access on every woman that comes into labor because we know they have the potential for a postpartum hemorrhage. At the point where they start to bleed, of course, we if they did not have an IV, we definitely want to put one in and start some fluids, normal saline or lactated ringers. So from there, we would want to make sure that the placenta fragment was removed if we think it was a placenta. The placenta, if we were just having problems with the uterus involuting down, we would do a uterine massage. If it was still boggy, we would want to empty the bladder because we know the bladder can put pressure on it. Then we may have to give some uterotonics. The uterotonics, again, being Methergin, Hemabate, Cytotec. Those are the big ones. And of course, the first line is Pitocin or oxytocin. If it firms up, we're good. If after these uterotonics, it does not firm up and apnea persists, of course, we need to start oxygen because we know that she's losing oxygen to her cells. Repeat laboratory studies, continue to give fluids. Of course, anytime anyone is bleeding, whatever's coming out, we need to put fluids back in. But remember, they do not have the red blood cells just from the fluid. We anticipate there is going to be a need for blood. A transfusion of blood. And then if it doesn't stop, then we're going to do surgical intervention, such as a dilation and curettage of the uterus, a DNC, or if that doesn't stop it, then we may have to do an actual hysterectomy. Here again, if we remove the placenta, we do a fundal massage and the uterus firms up, we're great. And then but we still see bleeding, we need to assess for a cervical or vaginal laceration. That would be a speculum exam. Hopefully we take them to the surgery, it's fine, we see what happens, but if it continues again, we're going to go down the same line. If there was a retained placental fragment, of course, we are going to call anesthesia, because we may have to take her back to the OR. We may need to give her some medication for this. I mean, we may need to give her some pain med. We may, dose up her epidural. We give a tocolytic. So we are going to give terbutaline to relax her uterus, so that we can go in there and get out the retained placental fragment. The provider does that. They relax it. Then, after we get it out, then we give the uterotonics, oxytocin, Hemabate, Methergin, and Cytotec are misoprostol. And then we hope that that fixes everything. If not, we're going to go back to the same triage, nursing intervention line. Oxygen, labs, fluid, blood, surgery. Lastly, it can be from a coagulopathy. So we may have some type of von Willebrand's, or we may have some type of idiopathic thrombocytopenia where we don't have enough platelets. We could also have HELP syndrome or DIC from preeclampsia. So we need to look for why we have it and what can we do to improve this scenario. Of course, we're going to give oxygen, continue to monitor vital signs, of course, blood and fluid, anticipate pharmacomanagement, antibiotics, vasoactive drugs, and uterotoxic tonic agents. So we're going to do everything we can to stop this bleeding. If we can't get it stopped, you guys, again, we're going to do a hysterectomy. So that's very difficult. Hypovolemic shock, that's when we don't have enough blood to circulate everything. We need to restore the blood volume. So just remember, when you give all of that fluid, the vasculature looks like pink lemonade. It's got so much fluid and not enough red blood cells. So please make sure that you understand that we have got to get some blood in there. Give medications and, of course, surgical interventions. And remember, anytime someone has a significant blood loss, they've lost their white cells, their macrophages, and their phagocytes. So you guys, they are at super high risk for an infection. Many times antibiotics are prescribed simply because we know they're at such high risk. Okay, so we talked about idiopathic, no reason, thrombocytopenia, low platelets, purpura, is an autoimmune condition. This is where there's an anti-platelet antibody that kills the platelets. It limits the lifespan of the platelets, so they're not available. Von Willebrand's disease is a type of hemophilia where they have a defect in the clotting protein, and so they cannot clot as well. So thromboembolic disease, of course, the rise in estrogen creates a significant hazard for women. For a blood clot, the incidence in etiology, one person in every 1 to 2,000 women. That is so high. And we've already talked about the clinical manifestations, medical management, nursing interventions. Do not be surprised if I test you on these again. Again, here's somebody with a big DVT. You can see her whole leg is swollen. You cannot point to a vessel that is inflamed. Postpartum infections, endometritis is an infection of the uterus, and usually it's from contamination from the rectum during labor, and it has a foul-smelling vaginal discharge odor, and we treat that with antibiotics. Wound infections, many times we can have a perineal wound infection where we had a laceration, or we had an episiotomy, and that can get infected. And so we tell them, warm sitz baths, it's been after 24 hours, just to keep it clean, and antibiotics. UTIs, such a significant risk factor during pregnancy due to epidural use, and due to stasis of urine, and due to sometimes poor nursing care. So you guys always make sure that you maintain sterile technique to prevent introduction of bacteria into the urinary system. And of course, for a UTI, we would prescribe antibiotics. Mastitis, again, you'll have flu-like symptoms with mastitis, unilateral breast pain and infection. Usually this comes from a poor latch where the nipple is lacerated or cracked. The bacteria enters, and then there becomes inflammation. Antibiotics and continue to breastfeed are the interventions there. We've talked about this. I think this is just a little reminder that the first sign of a postpartum infection is usually the fever of 100.4 on 2 separate occasions in the first 10 days. Prevention is really important. Hand washing, hand washing, hand washing. Pericare. Always have somebody wash their hands before they do their own pericare and afterwards, and of course the nurse as well. This is just a picture of endometritis where the endometrium is infected, and you'll have this purulent, foul-smelling discharge. And then here's a picture of mastitis. You can see unilateral redness, usually due to a crack in the nipple where bacteria gets in. Again, immaculate hand washing prior to touching your breast. And the clothes that the bra or support, whatever is on top of the cracked nipple, we need to make sure that we do a good job educating mom to keep everything super clean. Key points: hazards, hemorrhagic disorder, clotting disorders, be on your lookout, and the temperature of 100.4. Prevention of postpartum infection. Just tell them to void frequently, watch their bleeding, good hand washing, change their pad every single time that they go to the restroom. Okay, if you have any questions, please ask on the discussion board. Thank you.